Hello, and thank you for joining us. We are here to discuss a very relevant issue for behavior analysts, and that is whether behavior analysts should only use evidence based practices or if it's ethical to sometimes use non evidence based practices. While ABA is a field that firmly demands for its practitioners to use only evidence based practices, behavior analysts commonly find themselves on multidisciplinary teams with other professionals who do not share the same die-hard dedication for evidence based practices. I know one particular field that comes to mind for me is occupational therapy. Do any of you have experience with other disciplines utilizing non evidence based practices with your clients?
I've had the experience with SLPs or speech language pathologists as well.
I've had the same experience with my clients as well.
Yeah. Um, but so we'll get into all that as we start our debate that's going to be on collaboration with other professionals.
To start with, we're going to give an introduction of the topic and of ourselves. Then we are going to move into a behavior analyst scope of competence before moving to how to maximize client progress and promote independence. Next, we will discuss how this all may lead to increased possibilities of positive outcomes and how to prioritize relationships with clients and stakeholders, and we will finish up with concluding statements.
During this debate, there will be two stances that are argued. The first being behavior analysts should only use evidence-based practices or EBPs versus the stance that it is sometimes okay for behavior analysts to use non-evidence-based practices or non-EBPs.
Lastly, we want to outline the different sides of the argument and who will be on which side. So, for evidence based practices only, we have Danielle Spada and Caitlin Kirtley. And for against only evidence based practices, we have myself, Brianna Leader, and Alyssa Frazier.
All right, then, so we'll just get right into it. I want to start by arguing for the sake of only using evidence based practices, with the belief that it's unethical for behavior analysts to risk practicing outside of their scope of competence by not having the skills to maximize client outcomes when non behavioral interventions are incorporated into treatment. Behavior analysts, we are ethically obligated to implement interventions that are within our scope of competence, as it is stated within Core Principle 4, as well as Code 1.05 from the BACB Code of Ethics. The efficacy of non behavioral treatments for interventions for individuals with autism can vary greatly. The effects of non behavioral treatments will be unclear, with relative benefits and drawbacks that need to be weighed given the safety of the client, the needs of the client, the resources of the caretakers, and the other members of the interdisciplinary team. In these cases, to proceed in a manner that is consistent with the Behavior Analyst Certification Board, a behavior analyst would need to engage in questioning the professional from the other field, which could ultimately result in an erosion of a professional relationship due to questioning what their motives are, wondering, pressing for the science when there isn't a lot of science. It can make the other members of the team unwilling to include the BCBA on that team member for like IEPs and things like that regarding collaboration with the client. So providing non-behavioral services that a behavior analyst is not confident, it's also going to violate codes 2.01 and 2.16. So code 2.01 states that behavior analysts are to provide effective treatment. And they can implement non behavioral services with clients only if they have received the required education, formal training, professional collaboration, all that is necessary prior to the implementation of the intervention. It was stated in Code 2.16, describing behavior change interventions before implementation, that the behavior analyst is expected to provide in writing the objectives, the procedures, and the anticipated timeline of the intervention prior to implementation. If the intervention does not have evidence supporting it, there is no way that behavior analyst is going to be able to effectively construct an anticipated timeline for an intervention, which would then be making you go against this ethics code. The use of evidence-based practices, it's important because behavior analysts exercising poor judgment may engage in unethical practices and fail to properly identify ineffective treatments. There are non-evidence-based interventions that have caused harm or death to autistic children, which include chelation therapy and facilitated communication. Now, if you reference the table here, it describes these two widely implemented non-evidence-based practices that have been found to result in physical harm, psychological damage, and even death. Chelation therapy, it treats a client with autism with repeated injections of a pharmaceutical chelating agent into the skin or rectum across several months. It follows the belief that the excretion of heavy metals can result in improved autism symptoms. The side effects of this non-evidence-based practice includes burning at the injection site, fever, headache, nausea, vomiting, metal deficiency, and death. I've personally worked with different therapists that have had clients whose family use this, and they would report that the child would be foaming at the mouth during their sessions, would be non-responsive, blank face, that it was just, the child was completely different, and they were no less autistic than they were when they started the treatment. The other side of this table, it dictates what facilitated communication is about. This process utilizes a facilitator who provides physical support to assist client communication through pointing or typing. So it's a lot of hand over hand for the client. So this technique, it is claimed that those with communication impairments express themselves are failing to express themselves. So by having this hand-over-hand prompting, that they're able to generate the speech that these clients can't do on their own. But they're finding that more commonly it's the facilitator's words coming out, not the autistic individual's words at all. And it has resulted in psychological abuse of the clients, abuse of the families, and also client stakeholder legal battles over false allegations contrived by the facilitators, which has a lot to do with different molestation and rape claims that these facilitators generated all by themselves and used that the client's hand to spell out and claim that their families are doing awful things.
Okay, my name's Brianna, and I'm going to be talking about the rebuttal for only using evidence-based practices. A behavior analyst refraining from implementing a non-behavioral intervention in fear of creating conflict that may stem from unnecessary questioning of non-behavioral professional would be unethical. The field of applied behavior analysis does not have all the answers. Our professional domain specializes in behavior, but our clients commonly display needs in a wide variety of other areas. Though we are trained in behavior, adequate treatment for our clients often demands much more than what ABA can provide, and not all domains emphasize and prioritize evidence-based practices the same as ABA. It was stated in Code 3.06, Consulting with Other Providers, that behavior analysts are to arrange appropriate consultation with and referrals to other providers in the best interest of their clients. In addition, Code 2.10, Collaborating with Colleagues, stated that behavior analysts collaborate with colleagues from their own and other professions in the best interest of clients and stakeholders, addressing any conflicts by compromising when possible, documenting all actions taken and outcomes, and always prioritizing the best interests of the client. It is the behavior analyst's responsibility to be mindful of how others perceive them. If collaboration is lacking, the behavior analyst should engage in self-evaluation and problem-solving with an emphasis on doing what will result in the best outcomes for the shared client. To the right, you'll see a graph that displays a sample of U.S. children diagnosed with autism ages 3 to 17 years old. The graph shows that 56.1% of these children receive behavior services, 71.4% received speech services, and 60.1% received occupational therapy. This graph is from the work of Mons, Houghton, Law and Loss from 2019. These statistics suggest that behavior analysts are currently less frequently included on multidisciplinary teams. Knowing this, behavior analysts should be trying to be included in team efforts for their client rather than avoiding the opportunity. Behavior analysts should also be intentionally representing the field in a positive way while spreading the knowledge from our field and our emphasis on the use of evidence-based practices. Doing so could open the door to other fields utilizing more evidence-based approaches. It could also increase the likelihood that ABA will be looked at positively by other disciplines, and it could potentially lead to more families accepting behavioral services for their autistic child based on the professional recommendations given by the non-behavioral professionals who are currently working with those families. To sum up, ABA is not the only field that provides effective treatment for those with autism. A large number of children receive other services, such as speech, occupational therapy, that are proven to be effective and necessary. Behavior analysts should not only be team players on a multidisciplinary team, but should also promote the positivity and credibility of ABA and how it can work with other disciplines. In this way, more families could accept ABA into their lives and help their children. The next slide details the argument against evidence-based practices, and I will be discussing that as well. Behavior analysts should be able to use non-evidence-based practices when serving their clients. This can hopefully maximize improvements in skill acquisition, reduce maladaptive behavior, and promote overall progress. As such, the use of non-evidence-based practices can open more doors for those with autism, as they can lead to more opportunities for independence. Behavior analysts are responsible for prioritizing their clients' needs and serving them in the best way possible. Code 3.01 mentions that behavior analysts act in the best interest of clients, taking appropriate steps to support clients' rights and maximize benefits. In this way, if an alternative treatment is available that can help promote progress for clients, it should be worth reviewing. Although non-evidence-based practices to be carried out can help clients maximize their progress, it may be easier to have other paths to progress with the inclusion of non-evidence-based treatments. Furthermore, acting in the best interest of the client can allow for more options to be considered when it comes to treatment. As such, allowing non-evidence-based practices to be used can help maximize opportunities for clients to grow and prosper. As behavior analysts, we want our clients to be as independent as possible. Since no two clients are the same, it's best to seek out the most effective treatment for that client to foster independence. We should honor individuality and seek to adapt to the differing needs and learning styles of our clients.